Hi, my name is Erin Allen, and my evidence-based change project addresses the effectiveness of preoperative rehabilitation in the management of anterior cruciate ligament injuries. I am a certified and licensed athletic trainer working in a private physical therapy clinic in Northeast Ohio. I have recently obtained my Bachelor's of Arts degree in athletic training from Baldwin Wallace University, and I've been practicing as an athletic trainer for the past 3 years. I am currently pursuing my Master's of Health Science degree in Teaching and Learning from the University of St. Augustine for Health Sciences. So why did I choose this topic? Well, within my current clinical practice, I frequently encounter patients who have sustained an anterior cruciate ligament injury. The anterior cruciate ligament, or ACL, is located within the knee with the primary function of preventing anterior translation of the tibia in relation to the femur, and also provides rotational stability to the knee. Injuries to the ACL commonly occur in athletics, which is a population frequently treated by athletic trainers, and typically results in surgical intervention with an extensive rehabilitation program to return the athlete to their previous level of function. So during this presentation, I will identify the need to improve the current practice guidelines for managing ACL injuries and present my PICO question that has inspired my clinical practice change. I'll provide a synthesis of the previous literature and present the evidence supporting a change. I will share the change model that best suits my institution in the practice problem. I will also evaluate the outcome assessments of the evidence-based practice change and how I plan to disseminate the results and sustain this change. I will conclude the presentation with a summary and recommendations for both clinical practice and future research. So anterior cruciate ligament tears frequently occur in participants who partake in athletics. In fact, about 200,000 ACL tears occur annually in the United States, which indicates about 100,000 reconstructive surgeries, making this one of the most orthopedic surgeries performed. And according to the National Athletic Trainers Association position statement, the surgical cost of an ACL reconstruction ranges from about $5,000 to $17,000 per patient. And then following surgery, athletes partake in a 6 to 12-month rehabilitation program, which will further accrue even more medical bills. And with such a lengthy rehabilitation program, return to sport rates and the ability to return to your previous level of function are still surprisingly low. In fact, on average, 2 in 3 participants return to their pre-injury level, and only 55% return to a competitive sport. There is also a 6 to 32% chance that the ACL graft will re-rupture upon returning to participation, resulting in a secondary surgery. There is also a risk of a contralateral ACL rupture at a rate of 2 to 20.5%. Now, according to previous research, patients who have received preoperative strengthening and neuromuscular training had higher functional outcomes and return to sport rates compared to those who just received standard postoperative rehab programs. And within the physical therapy realm, patients receive preoperative rehabilitation prior to a total knee arthroscopy to improve their postoperative outcomes. But this same intervention is very much underutilized for the ACL population. Instead, patients quickly receive surgical intervention with hopes of returning to their sport much faster. But with a low level of individuals who have returned to their previous level of function and even to a competitive sport, I question why we're in such a rush to get back to competition. I believe there is definitely a substantial need to investigate the efficacy of preoperative rehabilitation in addition to traditional rehabilitation programs to provide my patient with a well-rounded rehabilitation and recovery experience and optimize their functional outcomes. So the practice problem has inspired my PICO question, which is for patients who undergo surgical repair for anterior cruciate ligament tears, how effective is preoperative rehabilitation in combination with postoperative rehabilitation compared to conventional postoperative rehabilitation in improving ACL reconstruction outcomes postoperatively in 2 years following surgery? So to begin, I conducted an electronic search utilizing the University of St. Augustine for Health Sciences Library, Google Scholar, and PubMed. And then during the initial search, I selected keywords using Boolean operators, which included preoperative rehab and prehabilitation that were highlighted within the titles. And then I utilized exercise, therapy, anterior cruciate ligament or ACL injury, anterior cruciate ligament reconstruction or ACL reconstruction as keywords highlighted within the abstracts of the articles. An initial inclusion criteria was determined using the advanced search option, which limited the results to peer-reviewed academic journals that are available in full text and produced within the last decade from 2009 to 2019 and were written in the English language. The inclusion criteria also limited the population age from 16 to 40 years old and located within the United States, and any reports that did not contain human subjects were excluded from this collection. The initial search generated 343 articles in total, each database returning the number of citations listed here on screen, and after eliminating the duplicates, I reviewed the titles and abstracts of the 278 articles to eliminate any that failed to focus on the influence of preoperative rehab, which refined the search to 17 articles. I then conducted an in-depth, full-text review of the 17 articles and ended up with 6 to finalize my collection. The primary evidence consisted of 1 systematic review, 1 randomized controlled clinical trial, 3 quantitative observational studies with pre- and post-test assessments, and 1 longitudinal non-experimental observational study. All 5 primary research studies utilized self-reported outcome measures and found that preoperative rehabilitation improved patient-reported knee function prior to surgical intervention, postoperatively, and sustained these improvements at 12 weeks and 2 years following ACL reconstruction. And then when I investigated the results of quadricep strength following preoperative rehabilitation, I got a lot of conflicting results from the evidence. A systematic review and observational study concluded that quadricep and hamstring strength improved following preoperative rehabilitation, but two other studies discovered that there was no significant difference in quadricep strength following preoperative rehabilitation, but they did notice that there were improvements in quadricep peak torque following the group that participated in preoperative rehab. Although the strength improvements were not statistically significant, they are clinically relevant because quadricep weakness is related to reduced function, quality of life, and an increased risk of re-rupture. An additional study also noticed a relationship between preoperative muscle activation, which improved postoperative muscle activation, and preoperative strength improved postoperative strength. There was 1 observational study with some pretty significant results that identified that preoperative strength was a significant predictor of knee function scores 6 months postoperatively. The randomized controlled clinical trial and systematic review both discovered that preoperative rehabilitation improved functional performance in the involved limb prior to ACL reconstruction and sustained these results at 12 weeks postoperatively. Superior return to sport rates were also noted 2 years following ACL reconstruction, following the implementation of preoperative rehab. So overall, the evidence supports that preoperative rehabilitation is a very valuable component in the early stages of ACL management to improve both quadricep strength, knee-related function, and functional performance following ACL reconstruction. Now, after my extensive literature search, I realized that there is a significant need for a clinical practice change. So to employ this change, I selected Cotter's 8-step change model here with the 8 steps listed on screen. And Cotter's model is the best suited change model because within my professional practice, there are a lot of professionals involved, and this can cause a lot of resistance. But Cotter's mindset of implementing the change, addressing these emotions that can rile up resistance, allows clinicians to identify and alter the inefficiencies to patient care. So utilizing these 8 steps, I plan to implement this EVP change into a physical therapy clinic in Northeast Ohio, and also include a local hospital with an orthopedic surgeon to ensure patient referrals occur for preoperative rehab. And then to establish a sense of urgency, I plan to present the gathered information to the clinical staff and physicians in monthly meetings. And my guiding coalition will consist of valuable stakeholders such as physical therapists, physical therapy assistants, athletic trainers, physicians, orthopedic surgeons, patients, and insurance companies. I will also utilize my clinical administration and marketing staff to help facilitate the patient referrals for preoperative rehab. Then to create my vision, I will highlight the impact on patient outcomes and revenues for the clinic and the success of the overall clinical practice following the implementation of preoperative rehab. I will share this vision by consistent communication with stakeholders, patient documentation of success, and highlighting patient improvements to the public, which will also help me sustain this clinical practice change. Then following the implementation of preoperative rehab, I plan to determine the best protocols for preoperative rehab to achieve the most significant patient outcomes, which will also help sustain the clinical practice change and alter the current clinical practice guidelines for managing ACL injuries. Now, to determine the influence preoperative rehabilitation has on ACL reconstruction outcomes, I will utilize both subjective and objective outcome measures that are valid and reliable. I plan to utilize the International Knee Documentation Committee Subjective Knee Form to assess patient-reported outcomes regarding their symptoms, function, and sports activity. I plan to assess quad and hamstring strength using an isokinetic dynamometer. I will assess functional strength with functional hop testing, which is a battery of testing that includes single leg hop for distance, crossover hop test, triple hop test, and the 6-meter timed hop test. And then time to return to sport will be the time recorded from ACL reconstruction to the time physician or orthopedic surgeons release the athlete to full participation. Now, I plan to assess patient-reported outcomes, functional performance, and quadricep strength in both intervention and comparison groups at 4 distinct time points. The time points include baseline measurement, which will be before preoperative rehabilitation, preoperatively, just before reconstructive surgery, postoperatively, which I have selected a 12-week timeline into traditional rehab, and then 2 years post-reconstruction surgery to determine the long-term efficacy of preoperative rehab. Time to return to sport will be conducted one time from the time of surgery to the time of return to full activity. The International Knee Documentation Committee Subjective Knee Form is a Likert scale, so therefore it's considered a nominal scale of measurement. And then the measurements of isokinetic muscle strength, time to return to sport, and single leg hop testing are all considered ratio scale measurements, And I plan to utilize SPS software as a statistical program to identify statistical significance. So to determine the differences between both groups in quadricep strength, self-reported outcomes, and functional performance at all 4 time points, I will use a repeated measures analysis of variance. And then an unpaired t-test will be used to assess the difference between both groups in regards to the rate of return to sport. Now, if the data shows that there is definitely a need for practice change and the practice change was successful, I would present these results to my institution in clinical staff meetings with all the stakeholders and present the results by using a visual representation displaying the patient outcomes following preoperative rehab and addressing the significant need for clinical practice change. I will utilize the clinical marketing staff to help conduct a seminar with local physicians and orthopedic surgeons to present successful patient outcomes following the preoperative rehabilitation and also capturing the potential for long-term benefits 2 years postoperatively. Now, to further my dissemination to the regional aspect, I'm going to focus on an important stakeholder, which is the athletic trainer. And since I plan to disseminate and initiate my EBP Change project in a physical therapy clinic in Ohio, I plan to deliver a professional practice presentation at the Great Lakes Athletic Trainers Association to disseminate my results regionally. And then to achieve the same goal nationally, I will deliver a professional presentation at the National Athletic Trainers Association Clinical Symposia. And then to reach out to another valuable stakeholder, which would be the physical therapist, I plan to deliver a presentation at the American Physical Therapy Association National Conference. And then to kind of collectively reach all of my other stakeholders, I selected a popular journal with the same mission of enhancing patient outcomes. The journal is called the Journal of Orthopedic and Sports Physical Therapy, and I chose this one because my goal is to modify the current clinical practice guidelines to improve the conventional management of ACL injuries. Now, all 5 primary resources and systematic review of the literature recommend and support the use of preoperative rehabilitation in the management of ACL injuries. Improvements in self-reported function and quadricep strength were consistent following the implementation of a structured preoperative rehabilitation program, which indicates a need for clinicians to address quadricep strength and activation in the early stages of ACL management to improve postoperative outcomes. Preoperative rehabilitation is warranted in the early stages to improve quadricep strength preoperatively and self-reported function postoperatively But preoperative rehabilitation cannot be implemented until the initial symptoms of an ACL rupture have subsided. Additionally, implementing rehabilitation in the early stages of ACL injury is beneficial to determine if surgical interventions are even necessary. It will help clinicians separate the copers versus the non-copers to ensure that we are performing patient-centered care. Now, prior research has utilized a variety of preoperative rehabilitation approaches, so future research is necessary to determine the most effective prehabilitation exercise protocol. Excuse me. And according to Ebel et al., these practice recommendations are at a level A due to the presence of one randomized controlled clinical trial and a systematic review of 8 randomized controlled clinical trials, all displaying consistent improvements following preoperative rehabilitation. Now, preoperative rehabilitation is a valuable component in the early stages of ACL management to improve quadricep strength, knee-related function, and functional performance. There is also a significant need to implement the preoperative rehabilitation in addition to postoperative rehabilitation to improve overall ACL outcomes postoperatively and sustain these results 2 years following surgery. So in summary, to answer my PICO question, there is a clear need to implement preoperative rehabilitation to improve patient function, quality of life, and quadricep strength. Cotter's change model is the best suited change model for my institution and will assist in the clinical practice change project. The evidence strongly recommends that implementing preoperative rehabilitation into the management of ACL injuries will provide improved patient outcomes following ACL surgery initially and sustain these results 2 years following surgery. There's also been a need for future research to further determine which is the best preoperative rehabilitation program. Now, my following slides highlight all of my references within this presentation. Thank you for your time and attention. If you have any questions, please feel free to reach out to me at the email provided on screen. Thank you very much.